great conversation this evening and settle in for some really great opportunities to learn some stuff. So the session this evening is going to be a really casual conversation. So the chat box is available for you to enter in questions, comments. You can say hi to your colleagues if you want to, but as the session is going along, please feel free to use it to just ask some questions. You can raise your hand. There is the hand raising option available to you, and Lauren and Shayla will be happy to answer your questions as well. There is going to be an evaluation link that's sent out to you along with some physician resource packages within 48 hours of the session. If you do not receive the resource package, please let me know and I'll make sure that you get that. Your CME credits and certificate will be sent out to you at the same time. So without further ado, I'd like to warmly welcome Carrie Barenko to our session this evening. Carrie Barenko is the Advanced Care Planning Lead for Fraser Health. We welcome Lauren Thomas, who is the Advanced Care Planning Nurse Clinician, and Shayla Behrens, who is the ACP Medical Lead. I'll hand it over to Lauren for now, but thanks again, and we're excited to hear what you have to share with us this evening.
Hi, everyone. Thank you for having me. My name is Lauren. I'm one of the nurses on the Advanced Care Planning team in Fraser Health. And we're obviously here today to talk about advanced care planning, which is sort of the first of a little mini series that April has so graciously arranged, because these topics of advanced care planning, palliative care, palliative approach, hospice, MAID, all of these things are really interconnected. And at some point have some crossover in some gray area. So we're really excited to be the first ones to go here for advanced care planning, because as you'll start to see, that advanced care planning is of course something for all adults, healthy, sick, young, old, doesn't matter. So thank you very much for having us, April. Just before we get started, I just want to give a quick little land acknowledgement here. Just to show our gratitude for the unceded traditional lands that we sit on. I personally am sitting in the Sami-Moo First Nations today, and I'm forever grateful for their stewardship of these lands. Advanced care planning has been something that has undergone quite the evolution, I would say, in the most recent even 5, 10 to 20 years. And so one of the things that we want to talk about tonight with advanced care planning is sort of demystifying some of the myths about what it is and what it isn't. And I think Rebecca Sidori sums it up very nicely in this quote here, because I think we get a little bit muddled. We get caught in the weeds when we start talking about advanced care planning and the clinical aspect with what our patients are facing. And so Rebecca always says, you know, the point of beginning advanced care planning conversations is not to force those premature decisions about possible therapies. So we're not providing patients and clients with a long list of a medical buffet, you know, yes, I'll take an IV, but no, I won't take a vent. But rather, it's really a process for patients to identify a substitute decision maker, someone who would speak for them if they couldn't speak for themselves, and really that process of articulating their values that, you know, those substitute decision makers, those families, those friends around that person can later apply to that in the moment decision. So when a crisis hits, we're prepared and ready for that decision-making process. And so that's really what we want to cover tonight, is sort of in these key outcomes, is look at, of course, the 5 W's of advanced care planning, and that's always the who, what, where, when, how, why. As I said, it's gone through quite the evolution, and so I think it's important to actually look at, well, what is advanced care planning? When and why do we do it? How do we do it? All these types of things. We'll touch a little bit on a pathways resource at the very end for you guys, because we're going to be going through a framework, and it's very nicely set up in pathways that you can reference back to later when you're back at your clinics. We're going to touch a little bit on decision makers, just a few things to consider when it comes to the BC Healthcare and Consent Act. So that's that big wad of legislation that says, you know, how do we get consent? What is informed consent, and who do we go to? Because very often in the world of healthcare, especially in our acute care facilities when there's a crisis, we're actually often going to the wrong person. Talk a little bit about processes, forms, and documentation. How can we stay connected between our community GP partners and the Fraser Health Authority? Not an easy task. We all have terrible, terrible systems. And I have a personal loathing and hate for Meditech, which is our internal EMR in Fraser Health. We don't have any perfect systems anywhere, and none of them speak to each other. So how can we communicate and create those connections? And lastly, we'll talk a little bit about advanced care planning as a team sport. And it's really not meant to burden prescribers, physicians, nurse practitioners. Advanced care planning, everybody has a role for that. And we're going to talk about what some of those roles can look like and how we can support each other through these processes. So often our team is out in the public. We do public presentations on advanced care planning, helping people put these plans together. And we hear all kinds of crazy stuff. And I'm sure you guys hear all kinds of crazy stuff in your clinics every day. But definitely people have the wrong impression when it comes to advanced care planning. So we're going to run through just a few of these myths, and we're going to show you the evidence behind why they're wrong and sort of lay that groundwork for what is advanced care planning. The first thing that almost indefinitely always comes up, especially when we're out in the community and speaking with, usually with seniors, they tend to come to our presentations more often, is they sort of say, well, I came because I have X illness or I'm an X age. I had a 92-year-old lady tell me, well, I'm 92, and every time people ask me how old I am, I check my watch because I feel like time is counting down. And so they have this idea that they think advanced care planning is for sick people, it's for the elderly, and it's a plan for death and dying, specifically those last few years of life. And advanced care planning absolutely is super important at the end of our lives, but it actually begins much, much earlier than that. And advanced care planning is a process, and that word process is really, really important because it's something that we revisit constantly throughout our lives. So it's a process that really supports adults at any age or any stage of health in understanding and sharing personal values, life goals, preferences regarding their future medical care. So that means a healthy 19-year-old should be engaging in advanced care planning. A 31-year-old newly diagnosed type 1 diabetic should be engaging in advanced care planning. An 81-year-old who may be cancer-free for 5 years should be engaging in advanced care planning. So it's really that reflective process of looking at your personal values. So who am I? What makes me me? What brings my life meaning, purpose, and joy? And what are those life goals that I'm sort of wanting to achieve? Because our healthcare decisions that we make definitely influence all of those goals. So really the goal of that advanced care planning process is to really ensure that people receive medical care that's consistent with those values and goals and preferences during serious and chronic illness. So by no means does that mean that patients or families can come in and demand things. Absolutely not. But advanced care planning really sort of embodies this concept of shared decision making, where patients are the experts in their values and beliefs. You guys maintain the expertise in medical care, and together we can make recommendations to suit the outcomes to really get people to where they want to go. The second thing often people say to us is, okay, I did my advanced care plan, it's done. Now I'm gonna go find my safety deposit box, I'm gonna lock it up with a key, and I'm never gonna look at it again. No, please do not do that. Again, advanced care planning is not a single event, it's a process. Because of course, we change, our lives change, our circumstances change, and therefore we need to reevaluate it, just like we reevaluate all the other planning pieces in our lives. And so what you see on the screen here is a graphic called the life planning model that actually originated with a lawyer downtown who partnered with ACP Canada to make this graphic to really talk about this concept of planning is planning. So every day, all of us, we engage in some kind of planning around our money, around our finances. And that looks very different throughout our lives. What I was saving for when I was 21 is very different than what I'm saving for at 37. Our goals change, our priorities change, people in my life change. People in my life are dictating how my money is being spent right now with a 7-year-old at home who loves soccer. So just as we plan for our finances, we do other planning as well. We plan for our belongings. We do estate planning. Great stuff to do. Get a will, you know, we always definitely highlight those things. or highlight powers of attorney, that kind of stuff. Very, very important. However, wills only work for us and really come into play after we're dead. So what happens in that huge chunk of time where we're maybe living with an illness or trucking along through life and maybe we have a sudden injury? So just like our money, just like our belongings in our estate, we need to have a plan for our healthcare. And that's really the goal of the advanced care planning process. Myth 3. Advanced care planning is about choosing specific medical treatments ahead of time. I have actually seen, and I would bet one of you have seen this, I have seen somebody bring me a long list of every possible treatment, ventilator, ECMO, feeding tube, IV, this or that, and they've got a long, check this one, oh no, I don't want that one, check that one. And I said, well, how do you know you want those things right now? And as a stable adult, you may have illnesses, but you're completely stable. How do you know you want those things? How do you know that they're a good fit for you? So we ask people to kind of set those things aside and actually engage in a 5-step process that is laid out by ACP Canada. And it's this concept of think, learn, decide, talk, record. So we want people to think about their personal values. Write down what brings your life meaning, purpose, joy. What do you do for fun? How do you spend your time? Who are the important people in your lives? This is the best way that you can sort of engage in a quick and easy values reflection about what matters to you. So then secondly, we want people to learn. We want them to learn about their own health issues. So what does my health issue mean for me today? What could it look like 6 months from now, a year from now, 5 years from now? What potential complications could I be facing? What treatments might I be offered? So really engaging in education and learning about their illness. The other piece of that learn is kind of two-pronged, is we really want people to engage in learning about the laws in this area, understanding the BC Healthcare and Consent Act and understanding the substitute decision maker hierarchy. Because we may call upon somebody to make a decision for them that they may not want us to call upon. 3, decide. Who's going to speak for you if you can't speak for yourself? Again, examining that substitute decision maker hierarchy and thinking about who really knows me best, who's going to make the choice that I would make if I had a voice. 4th, talk. Doing all this reflection and writing things down, maybe keeping a journal is great, but if you don't share it with anybody, and if you don't share it with those people who might be making decisions for you, it's not very useful. So regular conversations about values and about goals and where it is that you're trying to get to. Lastly, keeping some kind of a record for that. I don't know about most of you on the call, but I honestly can't remember what I had for dinner yesterday. So making a record of things and making a record of really important conversations like that is really important. It doesn't necessarily mean a document. So we tell people not to get hung up on that kind of thing. If you want to make a video or a letter or an audio recording to loved ones, however you can get that information down is really, really helpful. The last thing that we often hear in the public too is that advanced care planning is about completing legal documents. And so people, again, kind of forget about that 5-step method a little bit. And they run to their lawyers and they fill out a rep agreement or they fill out an advance directive, or they're completely lost and they fill out a power of attorney and they think that covers their health, which it absolutely does not in British Columbia. And they complete these legal documents and they go, okay, I'm done. Let's put it in a safety deposit box with that will and never look at it again. Understanding rep agreements and advance directives in British Columbia are really important. And for some individuals, they really would be an important key piece in their care moving forward. They're not needed for everybody, but to really understand their role. So lots of people always kind of say, well, I went to my lawyer and I discussed, my lung cancer and that's great, boom, done. I don't know about you, but I don't go to my hairdresser to repair my car. So you probably shouldn't be going to your lawyer to discuss your medical outcomes. It's probably a joint conversation that would be best fit for that situation. So those are just a few of the things that we sort of hear in the community very often about advanced care planning, and some of the sort of the myths and the confusion that's around the process. We get bogged down in a lot of the details. And so again, I always point clients back to that 5-step method to really kind of slow things down and deconstruct what does advanced care planning really mean for that person in their situation. So people are out in the community doing all these lovely, wonderful things, having great conversations at the kitchen table. And so ACP Canada ran a survey across Canada and sort of said, have you thought about this? Yes, 80% of Canadians have thought about their advanced care plans. Have you talked to your family? Oh, yeah. 70% of Canadians, they've had conversations with important people. And they said, well, and how many of you have actually talked to your family doctor? And it was like an abysmal, I don't know, 7-10%. And so often when we're in the public, we say to people, you know, you really need to be sharing some of this information with your family doctors. They're at the center of your care in the primary care world, and this is really valuable information. So sometimes this information can very easily obviously get lost when the Fraser Health Authority and our community partners are not very well connected, as I mentioned earlier. I won't say that gross M word again, but that EMR just drives me a little bit nutty. So how do we communicate? On the screen in front of you here are 3 common forms that we use in Fraser Health to communicate different things surrounding advanced care planning. So the center form is the advanced care planning record, and that is by and large the most important one. That's where if a patient comes to you and says, you know, I'm not doing too well with my health, but it's really important that I'm at my granddaughter's wedding in 2 months. That's something to really consider when we go to offer a client a treatment. They may want to say yes, that may create time for them, but they may want to say no, because that might hold them back from reaching that goal. So that goal is really, really important and should be recorded on the advanced care plan record in case there is a crisis and that client enters the acute care system. So these forms are barcoded and will be uploaded to the patient's EMR in the acute care system. How do we get them into the EMR? Well, we depend on a good old fax machine. It's 2022, and yes, we use a fax machine. So at the bottom of the advanced care planning record, if you or any of your staff are completing these, there's a fax number where you can fax that in, and then health records in Fraser Health will take care of uploading that document into the EMR so that it's in an emergency physician's hands when the client enters the emergency room. So the advanced care planning record really contains that narrative that's really important about the client. The other 2 forms on the outside, I'm sure you're very familiar with. The left is our medical orders for scope of treatment. So once we've had conversations with clients and we understand sort of what their values are, who they are as a person, you know, what goals are they trying to reach to, we can then make recommendations, medically indicated recommendations, that is, through a MOST. And the MOST form is also faxed to the same number, uploaded to the EMR, and stored side by side with the ACP record, because it's really important that we have that narrative and we have that medical order together to make sense for the client situation. On the far right is the identification of substitute decision maker form. And that is the legal substitute decision maker hierarchy listed out. It's basically a phone list. Our social workers use these very, very often in Fraser Health. It really tells us who's who in that person's zoo. Do they have legal paperwork that says they have a representative who's going to speak for them for their health care? And if not, who are those temporary potential substitute decision makers that could step into that role if needed? So that form really helps bring names and phone numbers to the top of the pile, so that we're not sifting through them or we're not seeking consent from the wrong person. So these are sort of the 3 main forms, pieces of paper, and modes of communication. Unfortunately, it is a bit of a one-way street. We don't have any way of getting things into your EMRs right now as it stands. However, when it comes to a crisis where the rubber hits the road is going to be the emergency room. And so I wouldn't doubt that you guys have a ton of super valuable information on your patients and clients that could be really vital to the ACP process and to decision making. I think I've spoken 20 minutes without breathing. So I'm going to pause here and just see if there's any questions, because I know the forms and the barcoding and all that stuff can be troublesome when our two programs try to communicate.
There's no questions in the chat yet, just so you know.
But if anyone on the line would like to take this opportunity to ask Lauren a question, please go ahead and feel free to unmute yourself and you can certainly ask.
Hello.
Hi.
Hello.
Hi. This is Saroj Kumar. And obviously it's a good information and need to be discussed with the patient in calm manner, and will take tons of time to fill those papers. So when would you be suggesting that we bring the patient in for those conversations? Because it cannot be just by the way talk. So I think it may be helpful to have a posters in our waiting room saying, please book a separate appointment to discuss these matters.
Yeah, absolutely. April, are you on that? You gonna make some posters?
I'll get my markers out. But
like that's an interesting suggestion, because we're actually going down that road at our Jim Pattison outpatient care and surgery center, because you're right. We sort of want to also create some public health awareness for clients, but also, every healthcare provider, regardless of the discipline, has a full load. And I don't need to tell you GPs that, obviously. I mean, I think you guys have the largest load of all. But we've got PT, OT, nursing, various disciplines who work in the building who are saying, I could contribute to these conversations. I could ask a question. I could get a nugget of information, but I need a little bit of a prompt. So a poster campaign is a lovely idea, and that's the road we're going down in JPOC, to remind healthcare providers that it doesn't have to be a 1 hour sit down, and get too deep. Sometimes it can just be one question, and get that information on the advanced care planning record and get it in the system, so that we create this story of that client and we create this this journey for them as they move along. So yeah, we're going to follow up with April on that idea. Thank you.
it's a great idea. And I know Advanced Care Planning Day was on the 16th, so just recently in the last couple of weeks here. And there are some great patient resources that are available that do that very thing, Lauren, about prompting to have that conversation, so that Dr. Kumar, like you say, it's something that is patient initiated, but that it's done in a separate time, because you're right, it's not just a happenstance conversation. It's a great idea. And yeah, we'll definitely be following up on those suggestions.
Yeah, thank you. Because it definitely cannot be done by the way, because a lot of people come for something else, their chronic disease, refill of the prescription and whatever. Yeah. And then at the end of the conversation, they say, oh, by the way, I'm going for dental surgery, or I'm going for septal deviation surgery. Could you fill my pre-op form?
Yeah.
And usually there is a pressure of time as well, because they say, oh, it needs to be done by this date.
Yeah. Any other questions or comments?
There's a question here about, I'm answering one, but the other one's just popped up about DNR and having difficulty choosing M3 versus C1. I think that's for Shayla.
Let me just bring up the chat. Yeah, that is a very good question. And it's really dependent on the patient's kind of illness and their values. So I don't have a, catch-all response or answer to that. Do you have a specific patient you're thinking about? Or is it just the difference between M3 and C1?
Well, I don't have a specific case in mind right now, but sometimes I have people saying, the options on the most form. So it's like BiPAP, nutrition, dialysis, right? So those are it. But then what else is there if we check off all that for C1? Do you have any specific, like a case scenario? I don't know. Can't think of one right now, but.
Yeah. So I think C1, DNR C1 is actually underutilized. And I would recommend, if you don't know, the specifics between M3 and C1 for your patient, it's probably safe to default to C1, because if they land in the acute care setting and they, are sick enough to require a consult from critical care, maybe they need vasopressors or, they need BiPAP, being C1 will make it very easy pathway for them. So the hospitalist physician or the internal med physician can easily consult the critical care team. If someone's an M3 and that's appropriate or not appropriate, because everyone's medical situation is in flux and is dynamic. Sometimes when the MRP gets on the line with the critical care doc and says this person's a DNR M3, I'm wondering if they should have pressors or BiPAP. Often they may be hit with, well, they're an M3, they're not for critical care, which may or may not be appropriate given the situation. So my recommendation is, if you ever don't know, you default to the higher level of care, which is C1. And just, in that box that has dialysis and blood transfusions and nutrition, you can do your own narrative and say, this patient, wants all possible disease treatments, but, has very clearly stated that they wouldn't want to be on BiPAP or they wouldn't want to be on X for a long period of time. And then that will then kind of frame the conversation for the physician taking over. I hope that helps answer that question.
There was a thumbs up there, so yeah.
Okay. Okay. Oh,
So we're gonna move on to a clinical example here, and I'm sorry, Shayla, that I named your clinical example Miss Apricot.
So I'm, for those who are either just logging on now, I'm Shay Behrens. I'm an emergency physician at St. Paul's. I'm a palliative care physician in Burnaby, and I'm a co-lead physician at Surrey. So I am slightly unique in that I kind of cross a few different health authorities in terms of where I work, but also different types of clinical scenarios, so palliative, home care, critical care, and emerge. And I'm going to walk us through a clinical example that hopefully demonstrates the utility and the importance of advanced care planning and how it's relevant to your patients. So yes, the name of this patient is Mrs. Apricot, but you may actually recognize her when the pictures come up. Next slide, please. Yeah, so we're going to start with the framework. So you can see there's 5 different categories on this slide, and the blue slides or the blue boxes are the different categories for your patients as they progress through their illness. So they start out as a healthy adult, then they may be diagnosed with, a disease of some sort. Then they may progress and be in the chronic illness and injury progression phase, which can be decades or more in terms of a fluctuating health status. And then things may progress and they may be more in a declining terminal phase of their life, and then the final days and weeks of life. And in the white box, at each of those junctions corresponds with the specific kind of action items or take-home points that we want you guys to consider for your patients. And you'll notice, just as Lauren had mentioned, a healthy 19-year-old, there are things to talk about, there are things to consider when they come through your office. So next slide, please. The patient whose name is Mrs. Apricot, also goes by Mary Tyler Moore. In this initial scenario, she's a 23-year-old healthy female. She hasn't quite broken into the Hollywood scene yet. She's experimenting with drugs and alcohol, much like most people her age are. And on one fateful night, she ends up drinking a little bit too much alcohol, and she's brought to the emergency department. The paramedics tell you, as the physician, that she was found in someone's yard. She has no identification on her, and it's before a time of, cell phones and electronics. So they have no way to identify her. She's visibly intoxicated. Her GCS is 8 at best. And so you send off some blood work, make sure she's not overdosed on Tylenol, make sure there's nothing else dangerous going on. And at some point she tries to, leave the emergency department. She's still very, very unwell from an intoxication perspective. And so the emergency physician is tasked with finding out who she is, who her SDM is she capable of making medical decisions at this point, and what is the right thing to do. So she is obviously not capable of making medical decisions. So you decide to keep her in the emergency department and let her sober up. In the morning, after all the blood work's done and comes back, and again, there's nothing dangerous going on. It was just alcohol intoxication. She's able to, tell you what happened. She's able to demonstrate that she understands, who she is, where she is, and what happened. And so she's safe for discharge. You can imagine that this is a very common scenario. But if this person, for example, had, developmental disabilities or mental health issues and was no longer capable of making medical decisions in the morning, we would really need to know who her SDM is. Does she have a representation agreement? Does she have, a legal document stating her wishes? And in emergency departments, sometimes that's information we don't have the luxury of finding. And as you are all, the GPs of these patients, you generally have a relationship and know what the care plan is and who their care network is. So filling out that form that Lauren had mentioned, the SDM form, and faxing that in would be incredibly helpful for physicians when these patients land in the acute care setting. So next slide. So 3 points that I just want to kind of talk about in that healthy adult section is consent, substitute consent, and legal documents. So the point with consent is we are only seeking consent if we are offering a treatment procedure or intervention. So consent is required when we give blood products, when we do surgeries, when we offer treatments. Consent is not required when a medical intervention is not being provided. So the clearest example of this is a very elderly, frail patient who has advanced dementia, advanced organ failure, and is at the stage in life where things are kind of falling off the rails. That patient is considered, at very, very high risk of not benefiting from something called CPR. So if their heart or lungs were to stop, that would not be a good situation, and therefore it is likely not medically indicated for them. So filling out a DNR or a do not resuscitate order is, you don't need consent from the patient, you don't need consent from their family members, because we are not providing that treatment for them. I think we all generally aim for consensus and agreement and awareness that someone is being, made a DNR, but I do just want to clarify that in terms of when we need consent and when we don't. And then substitute consent is when the patient is no longer capable of making their own decisions. And then, as Lauren mentioned, there's a whole hierarchy on that piece of paper of who we go through. And so it's really important if, for example, someone states that their great aunt is their substitute decision maker, that person is going to fall very, very low down that hierarchy. And so if that is in fact their wish and they've stated that to you, they put that in writing, it's important that that somehow gets transcribed into a legal document and faxed into the acute care setting. Because in an emergency situation, we go to the first one and then the second one and the third one until we kind of can make contact with whoever is available by phone. And then legal documents. So we do a whole session on this, but there's a lot of different legal documents, rep agreements, advance directives, power of attorneys. And if anybody has these, it's important to just ensure that this is well documented in the EMR. Next slide. So back to our framework. So we now had our healthy adult, and unfortunately we're going to progress in their disease pathway, and they're going to be diagnosed with an illness. Next slide. So at age 33, Mary Tyler Moore actually was diagnosed with type 1 diabetes. This is all accurate as per the Wikipedia page. She goes on to be a very prolific spokesperson for diabetes, funds research, and it really colors the rest of her life. So next slide, please. So as we stated in the white box on our framework, whenever someone is diagnosed with an illness, the action item or the to-do list involves education. And why we care so much about education is because it's giving the patient a roadmap of what to expect in the near, distant, and far future. It can give them an idea of, well, how this is going to change their health, how this is going to change their life. And I do want to mention that it's also very important to highlight the treatment options, but also the option of no treatment. So in the case of diabetes, this is really important because people with type 1 diabetes can quickly develop DKA. And in the setting of emergency, we see this all the time with patients who are non-compliant with their medications, with people who develop illness on top of DKA, develop issues with insulin management. And so giving people an outline of what to expect with their treatments, but also no treatments, is something that I highly recommend. And then the last bullet point here, so what happens when the treatments are no longer helping? I think it's important to highlight with patients that there is a ceiling effect with most of what we do in medicine. And this just opens the conversation early. So like a blanket statement that I find quite helpful would be with blank disease, there may come a time when X treatment no longer brings you benefit. When or if we get there, I want you to think about what would be important to you. So this just starts off the trade-offs conversation, and it plants the seed that medications, treatments, Western medicine in general does have a ceiling effect, and it's something to consider for down the line. It's really just planting that seed early. Next slide. So back to our framework. So now she's been diagnosed with diabetes. We've, provided a lot of education about, what it's going to look like over the next 5, 10, 30 years. And ultimately, she's going to end up in this chronic illness or injury progression phase. And this can be decades long or more, where someone will have fluctuating health events and may have periods of decompensation. In the case of Mary Tyler Moore, it's quite openly known that she also struggled with alcohol use disorder, which can complicate your diabetes management quite significantly. And so throughout this period for her, next slide, please. The things to consider would be shared decision-making. And so shared decision-making, next slide, involves both the patient and the healthcare team. And I'm just going to read this quote because I think it really quite clearly demonstrates what shared decision-making is. So patients and families are the experts in the patient's values, goals, and preferences, whereas medical professionals are the experts in the treatment options that honor that patient's perspective. Our recommendation helps translate values and goals into a treatment plan. So here you can see that you're both equally involved in the decision-making process. It's not, the patient, demanding or guiding the treatment, and it's not the physician, demanding or guiding the treatment. It's a shared process. And I've seen, and this is again through my palliative care lens, that patients and GPs who've had a very long and wonderful relationship over many years and have gone through this process over and over again as new diagnoses or new issues develop over time, that this can build a very, very strong bond. And from my palliative care lens, when I get consulted kind of at the very end of a patient's journey, the patients will often tell me, I think your plan is great. I'm sure you're going to make me feel better, but my GP has recommended this, and I know them through 35 years of care, they've delivered my babies, like they've done all these things. I think I'm going to stick with my GP in terms of the management plan. And that's totally appropriate. And it totally reinforces that the shared decision-making process is so vitally important. And I think what separates GPs from other types of physicians is that you guys have this long continuity of care and such a rich and full relationship with your patients. And so this kind of process, the shared decision-making process, happens over decades. Next slide, please. So after, multiple conversations of, treatment options, shared decision-making, maybe a completion of a most form throughout that process, you're eventually going to land in a point where you have increasing needs. So for Mary Tyler Moore, this was reflected in the fact that she had advanced kidney disease secondary to her diabetes. She had advanced heart disease, and she was essentially blind from the complications of her diabetes and alcohol use disorder. So near the end of her life, referral to home care services, private supports, these were all very important in maintaining her independence. So at this stage, we would recommend something called the Serious Illness Conversation Guide. And I'm just gonna take a poll, but you can advance to the next slide, please. Who, I don't know how, I guess we can do this informally. Either raise your hand or put a comment in the chat box. Who's heard of the Serious Illness Conversation Guide, or who's done it, or who has any idea about what I'm talking about? One. I see one. Oh, no idea. No idea.
Yeah, you've got some in the chat
right?
here. Yeah, 3 that are saying no.
Okay, perfect. So most are no, right? Okay.
From the people that have answered, yeah, for sure.
I can launch it actually here. I'll show you. Hang on.
Oh, look at that.
Oh, wow.
There, and everyone can
I can
complete.
vote. I'm going to say yes, but that's just... And then how do we see the results of that poll?
As soon as you tell me when you're ready, hang on, that is 18. I'll give people like another 5 seconds here to complete it. And then you should be able to see it.
You're a pro. That was so quick.
If you give me heads up, I'm a quick typer, so can you see the results?
Yeah, okay, so it's actually closer than we thought. It's 50, 47, and 53. Okay.
And there were some comments in the chat though, because not everybody responded to the poll, which is fine, but in the chat, people were saying that no, hadn't heard of it.
No. Okay, so I'm going to put the people who said yes on the spot here. And I'm just going to ask you, how did you hear about it? Did you take the course? Do you use it in your practice? Sorry to put you on the spot for being a participant.
I did a workshop at one of the conferences.
Okay, so you did like a one-day workshop or a couple-hour workshop?
It was just it was a short one.
Okay.
And there's a document that came with it.
Perfect. Okay, great. So previous workshop. Okay.
Yeah, and somebody else has written previous workshop. Yeah.
So the Serious Illness Conversation Guide, I guess we can skip to the next slide because that's where we kind of talk about it a little bit more in depth, is an evidence-based tool. So it's a structured conversation tool that helps you speak to people, patients, clients about their illness. It will ask specifically about their fears, values, wishes, trade-offs, and ultimately it will end with a recommendation. And it was developed by the Ariadne Labs and some wonderful physicians down in Harvard who then studied it. Dr. Atul Gawande has written pretty extensively about it in both the article by the New Yorker and also the book Being Mortal, which is an absolute must read. If you guys have any leisure time whatsoever, I would recommend it. And essentially, it's a very structured conversation, as I mentioned. And if you guys have interest, we as an advanced care planning group can, I think, facilitate education sessions on this. And it essentially just helps you to navigate these conversations, which a lot of people feel uncomfortable with. or don't feel like they have, experience with. And ultimately, from a patient perspective, will yield a really, really fruitful conversation, and you'll have an idea of their values, their wishes, and you can come up with a recommendation and often a decision towards, guiding their trajectory of care. The most important thing about all of this is that it's documented appropriately and transferably in a way that both the community physicians and the acute care physicians can access. So in the event of, if we go back to Mary Tyler Moore, so she also had multiple tumultuous relationships and a few divorces, but ultimately and her third marriage ended up sticking, and she actually married her mother's cardiologist that she met when her mother was in failing health. And now that she has, advanced disease in terms of kidney disease, cardiac disease, and blindness, she's had to make some hard decisions. And this is where I'm kind of going off the Wikipedia page, and I've kind of just gone rogue with the script. But she has clearly decided that dialysis would not be something that she would want. She's spoken to this at length with her husband, and she has discussed this with her GP. One day she is found unresponsive, and she's brought to the emergency department. She is found to be in a wide complex tachycardia. She's GCS of 6. We replace her electrolytes. We shift her because we think she has hyper K. We intubate her and we send her to the ICU, where she receives critical care and renal replacement therapy. All of this is essentially against her previously stated wishes. That just was not well documented in the acute care EMR, and we were not able to get a hold of her husband at the time of the kind of critical incident. So this is, obviously meant to illustrate the importance of these conversations and also the importance of documentation. But this is not an exaggeration. So I myself have intubated somebody who was a DNR M2. And the only reason we found out was because his wife, who was very, very adamant, broke through the trauma bay door saying, don't intubate him, he's an M2. So if that patient hadn't had such a strong and, persistent advocate to tell us this, we would have never realized this, because the documentation is just so cumbersome sometimes and so hard to find in a critical kind of time-sensitive situation. So the point of this part of the conversation is just to highlight the Serious Illness Conversation Guide. And if you have interest in pursuing it or looking into it, we can direct you to those resources. Next slide, please. So in the final weeks or days is when most people are referred to the palliative care services. Ideally, using the palliative approach to care, we want to be involved much earlier, but just in terms of resources and access to physicians, this is sometimes a challenge. And this is kind of the end stage of life, or the end of life care that most people will experience. Next slide. So in January of 2017, at the age of 80, Mary Tyler Moore was taken to the hospital and diagnosed with pneumonia. She was brought to the ICU, put on mechanical ventilation, and died approximately 1 week later of cardiopulmonary arrest. So I'm not saying that her death, or any death in the emergency department, the acute care setting, or ICU, is a bad death, because it's not. But what I am saying is, if it's against the patient's wishes or it's not medically indicated, that makes me worry that this has been, a death that could have been preventable, and the patient probably could have had a much more peaceful death with family surrounding them, or even in their home care setting, if we had a clearer directive of what their wishes were. So hopefully this Mary Tyler Moore case study demonstrates that the 5 steps of advanced care planning are useful for patients and are important. And I do recognize that it's very challenging to try and fit in these types of conversations when you guys have such a busy practice already. Next slide, please. And I'm hoping that you will take the some time to look at the Pathways ACP Tool Kit. Essentially, it's very much laid out as we did this example. So the 5 different categories, and there's interactive links that you can click on, like the Serious Illness Conversation Guide, the SDM forms, the MOST forms. So in your spare time, please take a look. And the next slide. And this is again referencing back to the comment that we had earlier about, you know, finding time to have these conversations, but also trying to have patients, you know, engage in them spontaneously. Advanced care planning is everyone's job. So you have MOAs, you have nurses, you have hopefully some allied health in your clinic. And so engaging everyone and asking them or finding ways to integrate it into their workflow is something to consider. The poster is a great idea. Lauren, what other things did we talk about with the JPOC team in terms of like the MOAs and things like that? I thought we had some good take-home points from before.
Yeah, really everyone has a role. And I think one of the things that really stands out for me is when we talk about that Serious Illness Conversation Guide. It's not a tool that's just for physicians or NPs in order to get out a medical order. It's actually a multidisciplinary tool. And so often I will try to call out my own colleagues, because when I see a fellow nurse with a blank MOST running after a physician saying, you have to fill this out, you have to fill this out, my first question for them is, what have you done to support that conversation where a physician may need to consider that MOST status? So really everybody has a role to play. And even when it comes to sensitive subjects such as prognosis, nurses, social workers, OT, PT, allied, all of these people all have a role in sort of talking about prognosis in terms of, hey, you come to the heart function clinic regularly and I've noticed things are changing. Things are changing and we should probably talk about that. So really, this is not meant to sort of say, doctors need to do more or to get, you know, you guys all have busy practices, as Shay has just sort of said. And so this is really a team effort. If you have registered nurses in your office, they absolutely can be trained in the Serious Illness Conversation Guide and do some of this information gathering for you before you approach that client, before you start to talk about, you know, the actual context of the medical situation that is currently plaguing that person. Our MOAs are absolutely vital in how this information moves through our system. And so if a nurse in your office completes an advanced care planning record, or you complete a MOST, our MOAs are really important people in making sure that this paperwork goes to where it actually needs to go. And then providing the tools and the resources to patients too, right? It's often patients and clients that kind of hang around the desk and drop little nuggets, drop hints, or ask our MOAs questions. And so having our MOAs prepared with brochures or information, or saying, oh, I saw Dr. So-and-so gave you a MOST. Do you have a green sleeve that you can keep your MOST in? Here's a green sleeve, take it home. So really this is truly an everyone job. And that's just all I wanted to say about that from the nursing lens.
Yeah, and certainly our experience at the neuro clinic at Jimmy Pattison, I think that we will all say that the office manager was key. You know, she attended all the education and then was very quick to say, oh, I know where we can fit this in, and I know where we can help. And I would suggest your MOAs are in that position as well. And April, I know we had some conversations too around you know, just providing some information to your MOA group as well. So I don't know if you wanted to say something about that.
So as we mentioned at the beginning of the session, this is the first of 3 kind of end of life conversations. So obviously April, 1 in May, and then 1 wrapping up in June for physicians. But at the same time in June, we're going to plan for an MOA session that will teach them about these forms and how to support you as family practitioners and where to send these forms, what resources to send home with patients, just so that your MOAs can learn to support you along the process as well.
And then I don't know what EMR everyone uses, but I wonder if there's like a little reminder or refresher, or, you know, at the time of a new diagnosis, or when you're doing a comprehensive review, if there's a way that it could be triggered as a reminder as well.
Yes, and I am curious if, you know, how often people use pathways. I'm hoping lots. We did a lot of work with a division in New West to develop the pathways pathway for advanced care planning, and really hoping that you'll find that useful. I did provide April again with a video clip. And so she was going to shorten it for us and for you, so that you, when you have some time, can actually look through that just to see how to click through it. I think it's a pretty good resource.
Yes, Dr. Tracy Monk kind of goes through the ACP Tool Kit that you can find on Pathways. So when the physician resources package comes out to you in a couple of days, the link for that shortened video clip with Dr. Monk will be inside of that physician resource package. So just like I said, if you don't get it within 48 hours, please reach out to me and I'll make sure that you get the package.
Yeah, Dr. Monk was great with that. I knew I wasn't the person to walk anybody through Pathways, so she did an excellent job with that. But back over to Lauren and Shay. I think it's opening up soon for just general conversation and questions, but over to you.
Do you guys have any questions about the specific framework and like each step along the way? Lauren, do you want to go back to just one of those slides?
I really like the Mary Tyler Moore theme here. Good job. Here, Lauren was looking for a Miss Apricot, and that's what she came up with. I like it.
I learned lots about her. Where, maybe I'll put it to the audience. Where are you guys having, or when are you guys having some of these conversations? And if you can think of your last one, was it brought on by, you know, someone in your clinic, or was it brought up by the patient or a patient's family member? Like, where are you finding these conversations are starting?
Usually we have like a complex care planning for patients with multiple comorbidities that qualify. So that one's a good start. But if they're not that sick, sometimes like they have hypertension or diabetes, and those are nice starts. But other than that, if they're relatively healthy, I don't usually start. But I'll keep that in mind to start.
Planting some of those seed kind of statements.
Some of the resources in the toolkit are really helpful because I think sometimes we feel like the onus is on us. And often when we're out in the public and we ask patients, you know, why haven't you talked to your doctor? Their response is simply, well, they never asked me, which is fair enough. However, we also need to help the general public take responsibility for their own health and for their own lives. And so you'll find that in the toolkit, there are resources for patients as well, not just for you in your practice, but also resources for patients. And so sometimes it can be helpful to say, take this booklet home and have a read through it. And next time you come back and you tell me what you think, tell me what you thought about, tell me about some of the conversations that you've had. To sort of just, again, like Shayla said, sometimes plant seeds. So sometimes it's helpful to turn the tables back on the client and sort of say, here's something to read. Go home and let that marinate and come back and tell me what you think about it.
Yeah. Another thought I'm having just as a good starting point, often when patients been admitted to the acute care setting and then they're discharged with a discharge summary, like it always says, you know, follow up with GP in 1 to 2 weeks for med review or to ensure things are going smoothly with whatever discharge plan they've set up. And often they've had to engage in some form of abbreviated goals of care conversation because every patient who's admitted to hospital has to have a MOST form. So that might be a starting point, you know, hey, you were admitted to hospital with this. The doctor doctors, filled out a most form. It says this, is this actually accurate? Now that you're healthy and well, like maybe we should reflect on this a little bit more. Do you have any specifics in mind? And then send them home with a My Voice booklet or send them home with some resources.
Mm-hmm. Yeah, one of the doctors messaged me just over to me and said exactly that. ER visits and post, hospital admissions, always great places. We have Sandeep that's asking where they can request, brochures and leaflets. And I guess I wanted to, again, Lauren and Shayla, you might not have seen it, but I did put in the chat, the advanced care planning team is available to answer general questions. And so we actually have a toll-free telephone number. So I did put it in the chat. And we also have an email address. But another thing that we do as well is do workshops. And so they are posted on our Fraser Health Advanced Care Planning site. And if you know people in your practice or even in your life, personal or not, we can certainly get together and do workshops. We just ask that there be about 20 people there. We can do them virtually these days, which makes things a little bit easier. And at those workshops, we really are doing pen to paper, so to speak, so that it's not just sharing information, but it's going through a booklet that we created, which is called My Voice in Action. And so it's just, the 5 steps of advanced care planning. And then we sort of do, a theory burst. What does think mean? And then really ask people to think about that and to sit in the space of their home with people. We talk as a group. What kinds of things should we write in it? So it's a fillable PDF document. So I think that, again, my sort of put out there too is, if you even in your practice have a group of patients that you think might want to do that you would want, then let us know. And if you can get a group of 20 together, we're happy to pop in. Again, that toll-free telephone number and email address, your patients can email or call us, and we can actually mail them out a package of materials. So that's where your patients can get that. That's where you get the green sleeve and the DNR forms. We can certainly send some of these brochures to you in print form, but probably not by the hundreds or probably even 50 necessarily. They are printable on our patient education site. So there's lots of different ways to get them. Most people are leaving the hospitals with green sleeves and with their forms, as well as in home health, which is really good. Lauren, I don't know if you had anything else to say, because certainly you're the one that's out there doing those workshops that are with the My Voice in Action, which of course you were instrumental in making. So you might say things much more eloquently than myself.
Yeah, no, we have lots of resources and leaflets and brochures. They can all be accessed through the Fraser Health Patient Education Catalog, which is available external, so anyone can access it. And all of the same leaflets, brochures, et cetera, are built into that toolkit in Pathways. So if you want to email a workbook or a brochure directly to a client when you're in the room with them, you can absolutely do that through Pathways. That was the intention, was to really speed up that process for you. DNR forms, medical orders for scope of treatment, advanced care planning records, those are also available on the Fraser Health external site. Under medical staff, those forms are available there. You can either print them out and fill them out, or they are available in PDF fillable if you prefer to just type or click directly into them. Green sleeves can be accessed from our team as well. So patients or clinics can contact us and request green sleeves for patients. But we're really finding that the informational brochures and leaflets are fabulous, but often I'm guilty of this myself. You read the information and then you kind of put it aside. I think there was an interesting comment earlier in the chat box about follow-up, and that there was this feeling that people don't put the same stock in their health that they do in other aspects, and I couldn't agree more. So the informational leaflets are great, but again, we want people taking that extra step of actually putting this practice or these conversations into action. And that's where people are really struggling. And sometimes they read the My Voice booklet, they get all these brochures, they have the information, but they don't know what to do next. And so some of our other resources are actually fillable, where patients can actually sit down and they're being asked questions in the booklet and that they need to write down and sort of get them really thinking about. So hopefully some of those resources can meet the needs of your patients and clients and families.
Hello, this is Dr. Kumar. Just wanted to ask you guys, when people are leaving with a green sleeve, when being discharged, how many people actually fill it, and what is the response rate you people are getting on that?
Like when they're in hospital.
Well, they are leaving with the green sleeve.
Yeah.
So when they go home, do they read it? Do they fill it? Or do you benefit anyway? Like you've been
Right.
distributing this for a little while.
Yeah.
Have you seen?
I will answer from the acute care side of things, but it might be a very different answer than Lauren and Carrie's answer because they have a better idea of what's going on the ground in the community. My understanding is that patients who are leaving the hospital after being admitted, if they have, a MOST form completed, that's a DNR or DNRC1 or whatever it is, it will be already completed and placed into the green sleeve, and then they will be instructed to place that on their fridge. Whether that actually happens or not, I don't know, but the form is already completed, the form is in the green sleeve, and the patient is discharged.
So that is the question. When you see people in emergency, do you have anybody bringing?
So the paramedics, when patients are brought in by paramedics and the green sleeve is on their fridge, the paramedic will look for that and will bring them in with the patient. Patients themselves don't tend to remember. So there's a lot of patients who show up who may have, a documented DNR or something in the EMR from their discharge, but the patient themselves doesn't recognize those terms, didn't bring the green sleeve with them, doesn't have a MOST form with them. So there is a challenge with just patient information and patient education and, patients being encouraged enough to take ownership for this. I totally agree. And so whenever I talk to patients about, their MOST status, I use the terms. So I say DNR M1, DNR C1, and I highlight it and circle that. So, if they can only remember one thing, that hopefully it's those letters when they speak to the next physician involved in their care.
So it might be just an idea. It might be beneficial when they are inpatient, somebody, paramedic, sit down and help them filling it. And same thing, as I said earlier, if we have posters in the waiting room, please make a separate appointment for those. The family docs can help filling those. But because this topic is never brought up, we are doing the reactive medicine practice. So we never get to see the preventive side of it. So that is very, very difficult.
I think a couple of things just that I wanted to sort of add into the room, and that is that we can't rely on patients and families to remember. I agree with Shayla, and that's why we are counting on people like yourselves out there to fax things into us. We have 3 forms. If you would fax those in, the emergency departments, and again, Shayla, you speak up here, you're an emerge doc too. They do look for them. I'm not saying they always have it depends on obviously what's going on with the patient at the time, but they want to do the right thing, just like you do, just like I want to as well. So they want to provide the interventions that the person would want. So it's so important that we get the information into the system. And but those are the MOST forms, right? Those are the MOST forms. Those are the advanced care planning records, which are ours. That's the identification of substitute decision maker, which are ours. But I would say that we have been able to increase what people are recording in whatever way they're recording by making that booklet called My Voice in Action and providing a workshop space for people to actually write things in it. We used to do workshops in the public all the time, and it was more of just giving them information. And so we created this other, document and forum for them to be able to actually write things down. So what are they writing down? They're writing down about what's important to them, what gives their life meaning, and what they do for fun, and they're sharing it with their families. And that's really what we want patients and families to do out there. So, again, Lauren, I would say it's increased because we've provided the avenue to do so. Is it perfect? Nothing's perfect. Are we getting, are we increasing things? I think we are. I think the information is flowing both ways. I think as, we have a younger generation of people out there who aren't going to sit back and are going to be very proactive in their healthcare and in their healthcare decision making. I certainly see it in my own children, and I see it in their friends in their mid-20s. Who are helping out parents and grandparents, and they're also thinking about it themselves. They've had friends who've had, accidents happen. So I think it's changing. Lauren has another slide that she talks about shared decision making and how that has changed over time. And I think we'll continue to see the differences in that. But Lauren, over to you too with just any other comments with that.
Just placed a link in the chat box there for you all to see the booklet that we've been talking about. It is in the toolkit on pathways. It is available on the patient education catalog. So the link is there for you for the PDF, which is fillable as well. So this can easily be handed off to clients, and they can learn a little bit about advanced care planning and actually get started in real time. There are other informational sources that we recommend. They're a little lower on the list. The BC Ministry of Health publishes an advanced care planning booklet called My Voice. And we've heard time and time again from many people from the public that it is too long, it's too detailed, it's confusing, it is cumbersome. And so I would definitely recommend the workbook that I've placed in the chat box here. In terms of content, that's all our team has. So I'm just curious if there's any other questions, comments, suggestions, rebuttals.